Hello and welcome to CJJ and NJJN's webinar on implementing evidence-based practices. My name is Katie Murphy. I'm the Communications Associate for CJJ. I just wanted to run through a couple of technical aspects of the webinar before we get started. First, you'll notice that all participants are in listen-only mode. If you have a question, we'll take those at the end, but throughout the presentation, you can type your questions into the questions box, and we can read those aloud at the end. Or at the end of the presentation, you can click the Raise Your Hand feature, and we can unmute your line and announce your name, and you can ask your question. And with that, I'm actually going to introduce our speakers. Francis Mendez is the Project Director for the Office of Juvenile Justice and Delinquency Prevention's National Training and Technical Assistance Center, which is operated by ICF International. Mr. Mendez is a practitioner with more than 19 years of experience in the youth development, delinquency prevention, and juvenile justice fields. His experience includes serving as National Director of Juvenile Justice for Big Brothers Big Sisters of America, Deputy Secretary for the Maryland Department of Juvenile Services, Chief of Staff for the Juvenile Services Bureau at the Connecticut Department of Children and Families, and Director of Advocacy for Covenant House in New York. Our second speaker is Beth Rosica, who is the Vice President of Administration for VisionQuest National, a nationwide provider of evidence-based services for at-risk youth. She also serves as the President of the Board of Directors for Advancing Evidence-Based Practices, an association of providers, model developers, researchers, and public agencies committed to promote the development, adoption, and effective implementation of evidence-based programs for at-risk youth and families. She has worked in the provider community for 20 years, serving youth in the juvenile justice, child welfare, and behavioral health systems. She has assisted her agency in embracing evidence-based practices and has been responsible for selecting and implementing numerous evidence-based models. And with that, I'd like to hand the presentation over to our presenters.
Thank you very much, Katie. And I think we'll just go ahead and move on to the next slide since we covered everything, to slide 3. And then if we could go ahead and do the first poll, we're going to try to get an idea of who our audience is today. So if everybody could take a moment and answer the poll, that'll help us make sure that we're addressing all of the right priorities for the folks who have joined us today.
So you should see the poll up on your screen. You can click your answer about what kind of agency you work for. We'll leave it up for about 30 to 45 seconds to just give everyone a chance to answer, and then we can show everyone the results.
Okay, thank you. So it looks like we have a number of folks from federal, state, or local government. That's the primary group of our audience. Some EBP providers, some SAG members, and a bunch of folks that fall into the other group. So we'll try to make sure that we gear our presentation today with all the folks in mind that are on with us today. So thank you, everybody, for joining us. And we're going to open the session today with talking just a little bit about evidence-based programs. I would imagine that most of the folks on the phone are familiar with evidence-based programs, but I want to just give a quick overview to make sure that everybody's up to speed. One of the first questions that I often receive from folks is, how do you identify an evidence-based program? How does it constitute that it actually is an evidence-based program? And there is a good bit of controversy on this topic about what is evidence, what is not evidence. And I generally like to talk to people about there being a continuum of evidence, that there's sort of the gold standard of evidence, and then it sort of goes down from there to the point where you get to no evidence for particular programs. But right now there are a number of lists in the field that generally people refer to when they're looking for evidence-based programs. And when I talked about that gold standard, the blueprints for healthy youth development, is what we think about when we think about the gold star. And so we'll talk a little bit about that list. I'm sure most of you are familiar with that. WISUP is the Washington State Institute for Public Policy, their list. They do a lot of work around the cost-benefit analysis, and so some people like to look at their list. The Coalition for Evidence-Based Policy, Crime Solutions. There are lots and lots of different lists. I left off SAMHSA's list, their NREP list. That's another list that folks like to refer to. But it can be confusing and overwhelming because you start to wonder, well, it's on this list, but it's not on that list, and how do you really know how to identify the best EBPs? So sometimes that is a challenge, and oftentimes states create their own lists, and we'll talk a little bit about that towards the end. So sometimes states are adopting a list that these are the kinds of programs that they'll fund or that they want used within their jurisdiction. Next slide, please. As I mentioned, a lot of people are focused on the blueprint models, and here's a sampling of some of the programs that are on the blueprints list. And sometimes these programs change. Programs can be added or they can be removed based on the level of research if they adjust the criteria. So a lot of people like to use the blueprints because they know that there have to have been 2 randomized control trials to show that the programs are effective and they can be replicated. Next slide, please. I'm assuming that most of the people on the call already recognize the advantages of using EBPs, otherwise you probably wouldn't be on our call today. But generally speaking, what we like to focus on is that it helps to reduce crime, reduce costs to taxpayers, we're saving lives, and there's lots of training and manuals and quality assurance that go along with the proven EBPs. The more rigorous of the models, like the blueprints, for example, have very specific training, licensing requirements, and supervision and follow-up. So with what you pay for, you get a lot more in terms of the support of the implementation of the program. Next slide, please. I want to talk a little bit today to the group that we have in terms of implementation about getting customer buy-in, because this is generally one of the biggest struggles that agencies have when they make the decision to implement an evidence-based program. And so if you can't convince the stakeholders, the people who are either funding the implementation or who are referring to the program, that this is a good reason, then we typically see challenges in the implementation. What I'm happy to say is that in my work with advancing evidence-based programs, the association that I head up right now, we see the conversation moving more from why to how. So it used to be that we would go in and really try to convince people that this is the reason why you want to use an evidence-based program. It makes sense, all of the items that I just covered on the previous slide. But now I really notice that the conversation is turning to, yes, we get it. We know we need to use evidence-based programs. We want to do that. But how is it that we do this successfully? So that's a very positive trend that we're seeing. One of the things that we like to talk about is leveraging existing resources as a strategy to introduce evidence-based programs. So all of the jurisdictions that I talk to, whether it's a state agency or a county, everybody's struggling with dollars. There's not enough dollars to do all the things that we want to do. And so how do we fund these evidence-based programs, because we don't have any new money to do that. And what I like to talk to folks about is trying to take existing resources that are maybe being used for services that are not evidence-based or are not working particularly well, and redirecting those funds into an evidence-based program. So there are ways to look at your current budget to see how you may be able to reallocate dollars to fund evidence-based programs if you don't have, the money necessary to get that off the ground. And the next point on the slide is that there are often challenges with getting people to think about using a different service as opposed to their local grassroots programs. Many jurisdictions have relationships with providers that go back 20 years, and they've been very happy with the services that they've provided. However, there may not be any evidence to support what they're doing is really working. I know as a provider, We have provided services that aren't always based in the evidence, and our goal is to try to provide as many evidence-based programs as we can. And we've partnered in a number of different locations to say, with our funders, you know, maybe what we're doing is effective, maybe it isn't. We don't really know at this point in time. So why don't we work together to change our program into something that is more evidence-based, maybe move to a functional family therapy or an MST implementation, and really work that together to see if we can get the kind of results that we're looking for. So I often think that as a funding agency, whether you're, you know, a state or a county or even at the federal level, if in fact you have providers that you like working with, engage with them in the conversation about what evidence is there to support their programs, and would they be willing to have discussions around changing program models to something that is more evidence-based. And I think that you'd be surprised to find that many providers are very open to going in that direction, particularly when there's a good collaboration between the funder and the folks that are placing the kids. There's also an issue sometimes, depending on the state, and we'll talk a little bit about this at the end with some state-specific examples, is that sometimes states have great visions of what they want to implement and what they want to see happen in the local jurisdictions, but sometimes those local jurisdictions don't always buy in, and there's a disconnect that happens between the state and the local folks. And really trying to get everybody on the same page and work together is really the goal that has to happen in terms of getting buy-in. Otherwise, if you have a disconnect, if the local folks who are referring kids to the programs don't believe in the evidence-based programs, all the good vision and leadership from the state will have no impact on actually getting kids to those programs. So those, I think, are important points to think about in terms of getting customer buy-in, because without that buy-in, you don't have the referrals and the program will not be sustainable. The other key piece with that, before I move on, is that all of these evidence-based models require practice. And the lack of referrals not only affects the financial viability of the program, but it really affects the clinical implementation of the model, because without consistent practice, the therapist or the staff implementing the program will never become proficient. And so that lack of referrals can affect the program negatively in a number of different directions. Next slide, please. So when we look at agencies that are trying to move into the evidence-based world, there are challenges that face them, and I can speak from experience over the last 10 years with my agency, VisionQuest, that we have had a number of challenges in terms of trying to move from a very grassroots organization that developed our own programs, that had, you know, very strong leadership, that wanted things done in a certain way, to moving towards evidence-based programs and practices in as many areas that we possibly can. And I think sometimes large agencies, while they have the infrastructure to implement evidence-based programs, sometimes that largeness creates different challenges, because you have so many different people in your agency that you have to really work towards seeing what the vision is and almost convincing them of the good reasons why we need to move in this direction. Certainly, you have to have the commitment at the highest levels of management. So if the president and the CEO and the COO and the board of directors are not consistently giving the same message that this is what we want, we believe it's the right things for kids and families and for our customers, if that group doesn't truly believe and embrace that philosophy, it's going to be very difficult to move that agency in the direction of evidence-based programs. The other issue that you have is that staff can really be threatened when they hear about evidence-based programs. One of the examples that I always give is that our agency started off in the community-based sector implementing evidence-based programs, so we changed a number of our services that we provided in the community to functional family therapy. And that was an easier place to start, because the folks involved sort of transitioned into that new service. But what ended up happening was that folks, our staff in our residential facilities became really threatened by some of those programs, wondering, am I going to have a job? Is the agency changing? What's happening? They're getting all of the attention, all of the focus is on the evidence-based programs. And then as we started rolling out some of the evidence-based practices into our residential facilities, some people liked it and other people didn't. And so that becomes an issue when you have existing staff trying to get them to make that change. And quite frankly, you will see attrition when you move to these types of models because they are very manualized. And some people feel that there's less room for creativity. However, I still believe that there's lots of room for creativity. The issue is that you're being held accountable to follow certain protocols, and somebody's checking to make sure that you do that in order to get the outcomes that we expect. And I find that many people, once they understand the rationale and the reasons behind the manualization and the fidelity and the closer supervision, really begin to embrace these models and enjoy having things very clearly structured and set out for them. But there are those folks who can adapt or choose not to adapt, and they end up leaving and looking for something that fits them better. So there definitely is a challenge with trying to maintain all of your staff, knowing that you will see some through the attrition process. I find that human services professionals definitely have a more difficult time understanding the value of research. We talk about it very easily in the medical field, and I always use the example that if you had cancer and there were 2 treatments that were evidence-based that you had at your disposal and one non-evidence-based treatment, I think that most people are going to go with what they know works because that's what's in the best interest of their health. And we often don't do that in human services. We know what works, we have research, but many folks are still married to their homegrown programs or what they developed because in their gut and anecdotally they know that these programs work, yet there is no hard evidence to support that they're getting any good outcomes, or even worse yet, that they could be doing more harm than good. So it is sometimes difficult to convince people of the importance to trust the research. When you embark on evidence-based programs, there's a lot of education and re-education and continual reassurances that we're doing the right things. As I said, folks are often reluctant, and even years after the fact of implementing evidence-based programs, I'll have staff say, well, I really like the way that we used to do things, and it's a continual process. It's not one that, okay, we're over the hump now, everyone's on board. It's a constant process. And family engagement can be a challenge, and Frances is going to talk a little bit more about the family engagement piece, but it is, we're working with reluctant and resistant families, and so sometimes that is a challenge, but that's what the models really help to identify in terms of how we can engage those resistant families. So I am now going to turn it over to Frances Mendez, and the next slide.
Thank you, Beth Ann. So we've heard about some of the things that are important in terms of getting stakeholder buy-in, some of the issues agencies may face in determining readiness. So I'm going to talk about, once you selected the program, you're ready to go, you got the buy-in, some of the things you should think about when implementing the program. And I'm really going to talk from the lens of a juvenile justice agency. What should they be thinking about to successfully implement a program? So on your screen, you see the components to successfully implement evidence-based practices and programs. This comes from the National Implementation and Research Network. I think it's always important to look at what the research says and let that be kind of the guiding framework for what we're trying to do. But I'm going to overlay that with the practicalities of real-world implementation. So we know that implementation of EBP is not easy. It's complex. It's fraught with challenges. And, I think competency drivers are important, making sure you have the right staff, they're trained, you have ongoing consultation. When implementing a program, you may, whether you select a national provider or a small provider, they may be starting the program from scratch. So that means hiring new staff and training new staff. And I think it's important to have that focus on quality and accountability, not only on the provider itself, but on the public service staff or juvenile justice staff that are working in conjunction with these providers so that they understand the program, have the competency itself, and can support the program. The other component is the organizational drivers, right? So this, providers will tell you that, in order for their jobs to be easier, they have to have the support of the agency that they're working with. So under this concept, there's kind of three drivers in that component, and one is the facilitative administrative support. So what this really means is that the agency is focused on identifying and reducing barriers to implementation, and that they want to create an environment that's conducive to successful implementation of the service. Systems interventions are important. So you're looking at how the program is being implemented, and you want to make sure that the delivery of service to the clients is going as planned. You want to make sure that the agency and provider are working and functioning as a cohesive team. And then third component is the decision support data system. So you're collecting data to really help drive decisions and really help drive this system intervention approach. And obviously leadership drivers are important. You need leadership that buys in, is investing in it, is willing to go invest in the long haul for these type of programs. I think another important thing to think about is that when looking at the implementation evidence-based program, not just thinking that, okay, we got this program, we're just going to make referrals to them, everything will be okay. That may not be, it may not work that way, especially the more you're dealing with youth that are further along in the system. If you're like diverting kids, that may work, but if you have kids that have probation officers or, court cases or even, kids who are on parole or reentry, it gets more complex and that coordination becomes important. So I would say that you really need an implementation framework that embeds the service in the agency's operations so that the agency is making sure that they're supporting the service. Next slide.
And Francis, I had one or two people ask for you to just speak up a little bit.
Sure.
Thanks.
Great. Yeah, so if we could have the next slide, great. So when you're looking at embedding EBPs in a juvenile justice agency or any public service, public sector agency, you want to do this analysis of, is this EBP a structural fit within the agency? Are there policies and procedures that may conflict with the implementation of this EBP? Is your infrastructure aligned with the goals of what this EBP is trying to accomplish? What are the, and Beth Ann alluded to this, what are the attitudes of the staff that are going to be working and implementing this? So you really want to launch this effort as a collaborative approach between the agency and the provider so that you can work out these issues and have a plan on the front end about how you're going to address it together. You definitely want to have the data collection framework, and I'll talk about that later on. And you want to make sure that this service is integrated into what you're doing. So we know that EBPs have their criteria and their referral service. But beyond that, how is the agency going to make decisions about what kids to refer? So one example is, I know other jurisdictions have done this, and Maryland has done this as well. They took their approach of assessing risks and needs of the kids and using that information in terms of family functioning and other criteria to refer kids that they thought could most benefit from this service, right? And you want to make sure that you're referring the right kids, and you want to make sure that you're getting it right the first time. So, one of the challenges that I've heard from providers is we get kids and families that have been referred to 7 services that didn't work for them, and now we got to convince them this is going to work. So on the front end, you want to be very deliberate about when you're going to make referrals, what's the criteria beyond the basic criteria, and when it's the what service is most appropriate to address the needs that the child and family is going through. You want to jointly address referral and engagement issues. So, and I'll talk about this later on, but if your agency has family engagement issues, that's going to impact the provider. And addressing family engagement issues or other type of referral issues is something that has to be done collaboratively. So what am I talking about? So usually a provider will rely initially on information provided by the agency in terms of the contact, the phone, the address. Unless the agency has a system to confirm that this information is accurate, you could be passing along information that's stale, so that it's you're unable to contact the family. You kind of have to go again and figure out how you're going to reach out to them. You want to establish formal communication protocols at the case level and system level. So what I'm talking about is really a multi-level approach to identifying and addressing barriers. So you want to have discussions about the cases and how things are working in terms of referral and working with the families and are you meeting the outcomes. But you also want to surface, the structural issues. What are things that are getting in the way? So what do I mean by that? Well, one example, if you don't have these things worked out, you could find yourself in a situation where you make a referral for a service, but then the kid is remanded or revoked and is put in out-of-home placement. So you want to make sure. So that means, okay, we have to look at our case management policy and when we're making decisions about do we we feel this kid is not meeting the conditions of their supervision or probation, and we have to go to placement. How do we factor into that review, if the kid is in evidence-based services, and how long before we make that decision? Next slide, please. All right, so in terms of setting a data collection framework, you want to build into the work being done, how are you going to collect this information, having people who are identified to review it, troubleshoot issues, and have the authority to be able to address the issues. So, my experience, it's important to, on the agency side, have staff that have responsibility to make sure that the service is being successful, so that you're not just relying on the provider. And in implementation, when you're starting off, referral and engagement issues is going to be a big challenge. Beth talked about, as you're starting up, if they're not getting any referrals, that that's an issue because some programs, they have to serve a certain number of kids for a certain number of time before they can expand. Here's the list of some of the things that are common when you're looking at referral engagement issues. So you want to track those so that you can address them. So for example, the provider should not be getting an incomplete referral packet, right? So if that's happening, what are the policies and procedures you're putting in place so that all the information is being collected? If the kid has already received EP services, they shouldn't be making a referral to providers. So how are you keeping track of who's had this service, who hasn't had it, etc.? So to kind of give you an example of collecting this data, go to the next slide. So this is an example from the Maryland State Annual Report for MST and FFT. So as you can see, the kind of #1 obstacle or challenge is that the parent is unwilling or unavailable. So you want to make sure up front that you're addressing this issue. You know, how is that handoff being made from the agency, you know, the probation officer or case manager or parole officer to the family? How are you making sure that connection is happening? So there, you know, there are things depending, you know, on the flexibility. There are things that you can do to try to facilitate that. So, for example, some of the things, my experience that I've done is actually having the provider be there when the information is presented to the family, when possible. That may not be possible all the time. But you really want to look at your systems and make sure you have things in place to address it. So I'm going to talk a little bit about, you know, family engagement barriers. If we can go to the next slide. Great. So you really, you know, if you're implementing evidence-based services, you're serving that require, you know, cooperation of families and working with the families and the kids, you're going to surface, if you don't have strategies in place to address family engagement, that's going to surface that issue to the top very quickly. So you really want to figure out, you know, are what we're doing, are we creating an environment that's conducive to family engagement? And there's some things to think about from this article that's cited in the bottom, Engaging Multiple Families and Treatment, Lessons Learned. So you want to make sure that this program, this evidence-based program, is marketed and communicated properly to the families, right? If the folks making that referral are not enthused, don't understand the program, don't buy into it, that's going to be communicated to the family. So by the time the provider reaches out, the family say, oh, I'm not interested, or I didn't understand. So that requires, you know, approaches where you're making sure that you're training or identifying people that can market the program well. And, you know, this, you know, another challenge that providers may face is that families may think that this is just an extension of supervision or court involvement. So you really want to say, no, this is a program to support, you know, the family. You want to acknowledge, you know, the role they can play and pitch this as a supportive thing. So you can see the other kind of things you want to look at. So another one is, is the time convenient for the family, right? So setting up meetings to talk about this during work hours may be difficult for some folks. So that brings issues if you're an agency with your staffing in terms of, you know, what days and times they work, etc. Or, you know, or the provider may have to have someone at the courthouse, right, when these decisions are being made and these referrals. So these are some of the things you want to think about when assessing, you know, do we have an environment that's conducive to family engagement. Next slide. So you see the source in the bottom. So these are some good strategies that can be applied generally, but, you know, it's referencing FFT and MST. And I alluded to this a little bit, but trying to build a relationship prior to the first call or appointment. So whether that's involving the provider in that call or the, you know, probation officer or court officer or case manager understands the program, is exposing them to the program, or they're providing literature or inviting folks to orientations and talking about the program. You want to leverage existing supportive relations in this process. So are there already people that have a good connection with the family that you want to work with in providing the service? You know, using strategic and strength-based marketing so that you're pitching the service in terms of how it can help them communicate better as a family, can help support the strengthening of the family, and obviously identifying and addressing and removing participation barriers. So, you know, whether it's the hours, whether it's you know, making sure that the service and what the agency is doing is not conflicting is very important. So, next slide. So I said that it's important to have this framework where you have you're trying to embed the service in the operations of the agency, right? So that you have staff aligned that are going to focus on this and support the provider. Your policy and procedures are aligned, but you also want to make sure you're setting that structure so that the provider and the agency are working together. So this is kind of a visual, you know, kind of summarizing the things that are important to successfully work together and implement this. So you see in the bottom the goals. You want to have a coordinated and collaborative process. You want to have joint responsibility for identifying and problem-solving issues. You know, as I mentioned, system interventions and tracking outcomes and quality improvement. So on the top, you'll see some of the kind of activities that I think are important to achieve that. And I mentioned previously the case management process should support your implementation of the evidence-based services, that you're tracking, you know, the referral outcomes and analysis. You are integrating family engagement. You have that communication loop so that if something's going on and it keeps repeating, you can surface that. You can address it as a team. And you know, one of the recommendations I would make, you know, I said earlier, is identify people that have responsibility for doing this, and especially if you're rolling it out, piloting it, folks that have been trained, that buy into it, and that understand it. That's very important. One example that comes to mind in implementing an evidence-based services in a jurisdiction, we realized that the best probation officers weren't referring kids to the service. So we were kind of perplexed until we realized that that's because, you know, they really felt they were providing a service. They were the case managers, and they felt that the service was kind of, you know, taking their role. So that was kind of interesting dynamic. So you know, so it's not necessarily folks that don't buy in to helping kids or are more, you know, supervision focused or social control focused. It may be just clarity of roles, right? Who does what and how do you work together? So these are things that I would say are important to be able to successfully implement evidence-based services in an agency. So I will turn it back to Beth Ann to talk about funding and sustainability.
Thank you, Francis. If we could have the next slide, Katie. I want to talk a little bit before we wrap up about funding and sustainability, because these are big issues from both the provider perspective and the agency that's funding the program. I want to be clear that, you know, once you've made the decision that you're doing evidence-based programs, it's as much work to stick with it as it was to make the decision to do it. And I think that that's a really important point, because we talk about model drift. It's easy when you have human beings involved that once you get going, people think, oh, well, I could make this tweak, or I could do this a little different, or I could take this shortcut, and it's really not going to affect anything. So it's really important that you have good quality assurance procedures, and a lot of the models, particularly the blueprint models, have all of that built in to make sure that there isn't model drift. And if they start to see model drift, then it's addressed immediately through the adherence and fidelity protocols. So I think that's a really important point to make, that it's not just like you make the decision, you get started, you get trained, and it's all good from there. You still have an ongoing amount of work in terms of making sure that you're doing things correctly. I talk a little bit about that when you buy these programs, you do get a lot of support and supervision, but it doesn't wash the agency's hands of the quality assurance function or the infrastructure to support these programs. What we found at my agency at VisionQuest was that we actually needed a different type of leader to head up our evidence-based programs than our more traditional programs, because it does require a high level of discipline to make sure that you're sticking with fidelity. So we actually had to create a position within our agency to oversee our evidence-based programs and the replication of those programs, and that's worked really well for us. Whenever you have staff turnover in an evidence-based program, it is really difficult to manage, much more so than in a traditional program, because in a regular program you might have somebody that you could pull to fill in, to cover. In an evidence-based program, there isn't anybody else to cover or fill in, because you have to be trained in the model in order to deliver it. So if you have to get a new staff trained, there might be a lag time, a month, 2 months, 3 months before you get the position filled, before you get the person trained. You run the risk of decreasing your revenue because you're not providing services, and obviously you decrease customer satisfaction because your funder isn't happy that you're not able to provide the services that you said you were going to. So managing staff turnover is a key in terms of maintaining a stable, both financial and clinical environment for the programs. Collaboration, I've talked a little bit about this earlier. It definitely requires a higher level of collaboration to make sure that the referrals are coming in, that you're getting the correct referrals, and the folks on the ground, the probation officers or the caseworkers who are doing the referrals, really understand the program, the target population, and they're buying in that they think that this is going to work. I've seen it happen in more instances that the local line staff of a jurisdiction can sabotage these types of programs because they simply don't refer to them, and they continue to refer to the homegrown programs. That's why that readiness piece is so important, that if a county or a state hasn't done the background work to educate all of the folks making the referrals and getting buy-in, it's a very, very slow process to get these things started. And lastly, I want to talk about the fact that evidence-based programs are more expensive at the front end. That, a lot of these programs cost $30,000, $40,000, $50,000 a year in licensing fees just to get the training off of the ground. In traditional homegrown programs, you don't have those upfront costs. And so as a funder, I highly suggest that if you want people to use evidence-based programs, you may want to consider some startup dollars for the initial implementation to make it easier on the provider. Otherwise, what the provider has to do is to build in those costs into the year that they provide service to be able to recoup those costs. So it is challenging at the beginning to get the funding mix correct. Now, the good news is when done correctly, these models will actually save money over time, because you'll have less kids in further penetration of the juvenile justice system. You can avoid costly residential, and then the whole cost benefit of the reduced crime that costs taxpayers dollars. So you will see the savings, but initially you are going to see an uptick in your expenses, both at the provider level and the funder level. Next slide, please. And I know that we're at 2:45 and we want to make sure that we have time for questions. I just wanted to give a little bit of an overview of some of the states across the country and what they're doing with evidence-based programs. Our association, the Advancement for the Advancing Evidence-Based Programs, completed a report last year that did a comparison of all of the states and sort of where they are in their implementation of evidence-based programs. If anyone's interested in that publication, my email will come up in a few moments. You can feel free to email me, and I'll make sure that we get you a copy of the report. It's quite interesting to see how different states are doing, and some states that you think would be doing really well may not be, and vice versa. The state of Delaware is doing some really interesting things in terms of their high-risk population and the services that they're providing for kids. They're using a number of evidence-based programs, both FFT and PLL, Parenting with Love and Limits, aggression replacement training, CBT. There's a number of services that they're using in the community with their high-risk juvenile delinquents. So they're doing some good work there in Delaware. Pennsylvania has what's called the Epic Center out of Penn State University, and they are really driving the process to work with counties. Pennsylvania is a very strong county-based system, and so each county really, is their own domain and how they operate, how their government works. But the state laid out a path, a vision for what they wanted services for kids to look like, and the Epicenter has done a really nice job in terms of supporting specific evidence-based programs, and they have a list of programs that they really want for counties to be focusing on. The state of Maryland has a fairly big evidence-based initiative as well, and they have a project through the University of Maryland, the Innovations Group, and they help manage a lot of the evidence-based programs, FFT and others that are being implemented in Maryland. One of the things that you'll hear sort of throughout this is that some of the states that have really good wide-scale dissemination of evidence-based programs have some sort of hub within their state that helps with the vision and the implementation of evidence-based work. So Pennsylvania and Maryland, through affiliations with universities, have that hub. And in some instances, they actually provide the training in the evidence-based models. They contract with the model developer like FFT or MST to provide the training to the providers. So those types of situations seem to lead to wider dissemination of evidence-based practices. California has the same type of thing with their CIMH group. So they really set the list of, here's the approved evidence-based practices. We will provide the training costs and the training to be able to do that. Louisiana is an interesting story. They kind of went from the tail end of having no evidence-based programs to really moving way up the board to having a high number of evidence-based programs. I had the pleasure to be in Louisiana last week at the Louisiana State University Institute for Public Health and Justice with Stephen Felipe, where we put on an evidence-based academy for a number of jurisdictions that had an opportunity to look at what their system is currently doing and where they'd like to get to. So we had some parishes from Louisiana, we had some states there and some other local counties, and we spent 2.5 days really looking at their needs of their kids and their community and what could they do to move towards more evidence-based services. So it was a phenomenal opportunity to get to see the great work that Louisiana is doing. And like I said, they've gone from having so few evidence-based programs that they're moving to the top of the charts. So I think at this point it's 10 of. I will stop and open it up for questions so that we can make sure to address any issues that anyone would like to talk about. So thank you for your time today.
Thank you to Beth Ann and Francis. As I said, you can type your questions in the questions box, or you can use the raise your hand feature. I will say if you're on a cell phone or your audio connection isn't that great, to use the questions box so that we can read those aloud to avoid any audio features. While I'm letting people type their information in, I will say that the recording and the PowerPoint of this webinar will be available on CJJ's website within 24 hours. I've also put up on the screen the contact information for both of our presenters, so you can contact them with any follow-up questions that we may not get to if we don't get to your question. So I'll just give everyone about a minute to enter their questions.
Katie, while we're waiting for questions, I did want to talk a little bit about this move by certain jurisdictions to use evidence-based services as an alternative to out-of-home placement. Some jurisdictions who are focused on reducing kids in out-of-home placement make the case for investment in the service to reduce that. What I've found is that you really have to have a structured system for how you're identifying that you really are serving kids that you're trying to prevent from being incarcerated or from being placed at a home placement. Because what you don't want to do is invest in the service, you know, and then still have the same number of kids in that home placement. You want to make sure that you're referring the appropriate kids that have that higher risk level, if that's your target population. One of the things we did in Maryland, in addition to increasing the number of slots and implementing new evidence-based services, is that we also worked with some providers to shift the population, right? So EBPs were being used more as, you know, a kid in the front end that maybe got, you know, arrested the first time, but, you know, most likely, you know, as you know, 50% of kids who are arrested don't come back. So it's a great preventive service, but, you know, if you're trying to make the case for investment and get more money, that's one way to do it. Another thing to think about also is, are there slots partitioned for certain specific higher risk groups? So I know in Connecticut, that's one of the things we focused on, making sure that there were slots dedicated to the more higher risk youth, because obviously those are the kids that most need it, but they're most difficult to serve, most difficult to get their families to be engaged. But if you have that mechanism where you can make sure these are the kids that need it the most, and that facilitates things to generate investment like compacts. So that's one of the things, you know, Maryland did, which is, you know, get investment for the service in exchange for saving money, which would then be reinvested again.
Okay, we have our first question is, how do you engage a resistant parent to engage in services for youth?
Francis, do you want me to start that one, and then I'll turn it over to you?
Sure.
Okay, great. So typically, the models, particularly the blueprint models, have a number of strategies for engaging resistant youth, and that's a lot of what the model focuses on is for the therapist, what are the strategies that you use for family engagement, and usually that's sort of the first phase for how you work with that family. From the first phone call about how you get in touch with them, and I know Francis talked in one of his slides earlier about that collaboration between the referring agency and the provider, because if the referring agency hasn't done any groundwork with the family about the services that they're going to receive, it does make it very difficult for the provider to come in cold. So one of the strategies is that the funder or the placing person explains to the family what the service is and what they're going to get out of it, and to let them know someone will be in contact with them. And then usually the provider is in contact very quickly thereafter, so there's no lag time. Other strategies include making sure that the therapists are matching to the families, so that you want culturally relevant folks delivering services to the families that they're working with. And then, like I said, the models, each model has a different way of how they approach that. So, for example, FFT, one of the things that they focus on is not placing blame anywhere in the family and meeting the family where they are. And so there's these clinical structures that are put into place that help families feel more comfortable and not on guard to be able to want to participate. And that's really the goal of all of these programs, is to figure out ways to get the family to want to participate and continue to come back. Francis, do you have additional thoughts?
Yeah, from an agency perspective, I would say one of the things that's important is if a kid is resisting or not showing up to appointments or not collaborating, that is addressed through the supervision of the agency, right? So that, you know, you don't have a situation where, you know, probation can say, oh, you're doing great, but they're not showing up to their appointments. And in terms of the issue of whether you're going to integrate this into their supervision plan or, you know, attach sanctions, it's a mixed bag, right? I've seen jurisdictions that make it a requirement and it works because, you know, it's serious, and others that prefer not to force kids to do it, that you really want to, you know, not make it a condition of their court supervision. So I think it's more of a local choice of what you think works, but I think the agency needs to play a role in holding the young person accountable if they're not participating. I think the provider always does a great job of, you know, talking to the family and trying to get the kid on board. But, you know, that's why I said earlier, it's very important to get it right, because most likely the resistance youth are youth that kind of been to 6 programs that really didn't meet their needs and are kind of jaded. So you want to make sure you're not, you know, you're accounting for that so that you're not referring kids to multiple programs. You're getting it right the first time.
Great. Our next question is, on average, how long does the process take to fully implement an EBP so that it is running smoothly?
So I think that's a great question, and it's really dependent on the EBP. So if you're talking about one of the blueprint programs like FFT or MST, you're talking about, for an agency that has never done evidence-based work before, it's going to be a good year before you're even at the place where you kind of have a good idea of what you're doing and how things are going. And we generally talk, for a new agency, new to evidence-based practice, it's probably 3 years before you have all of the kinks worked out of all of the implementation issues. For agencies that have more experience doing evidence-based work, that time can typically be cut down to a year because once you've done one EBP, replicating others becomes easier because you have an infrastructure and a system in place to deal with the fidelity. Regardless of what the program is, the fidelity process is generally the same in terms of what you're looking at. So it does take a lot longer to get these programs running well than traditional homegrown programs.
Okay, our next question is, do you have any suggestions on how to start to develop a data collection framework?
Francis, do you want to take that one?
Sure. So, you know, in Maryland it was a little bit easy because, as Beth Ann mentioned, we worked with the University of Maryland Innovations Institute to create that hub where we were kind of relying on them to do the data collection, to provide quality assurance, and they were able to work out agreements with, you know, the FFT, MST developers to have access to their system and do reports. So, you know, I'd say start with the basics. You know, unless you have a database that's collecting this information, you know, you get the provider to report it to you. You know, they'll, as part of their process, they're going to be collecting how many referrals, you know, how many were engaged, how many weren't, and having a committee or people designated to review that information. But, you know, in the slides, there's some of the things that, you know, I mentioned you're going to be looking at. But as you know, if you have a way to identify where the challenges are, you know, those are areas you can start to collect information. And you know, I would add, you know, for those in the audience that are, you know, part of state advisory groups that are guiding the funding, you know, of EBPs and practices, you know, it is important to emphasize the data collection so that you have a way to make sure the EBP is being implemented correctly. Because if you don't have that in place, then, you know, instead of a year, 3 years, it's going to take a long time before you start to see the results from that.
Okay, our next participant says, we have someone who is looking at evidence-based programs. They have buy-in from program staff, but less buy-in from organizational leadership. What advice do you have?
Well, I think that, like I said, without that buy-in from organizational leadership, it's definitely a challenge. And so I think that you have to find ways to connect with those folks to get them on board, whether it's sending them articles about evidence-based work, maybe having someone come in and speak if you're able to set up some sort of meeting or conference on evidence-based programs. Our association, Advancing EBP, has a lot of resources. Our executive director, Peter Greenwood, speaks at locations all over the country trying to do exactly that, get buy-in at the high level for the reasons and the rationale behind evidence-based work. I think that if you can find one person at a higher level that you could sort of get to individually and maybe have them be the face and the champion, that's another way to go. One of the groups that I was working with last week in Louisiana had some folks from the governor's office there, and so those folks were really interested in hearing about this and how it works, and they were going to go back and try to get everybody on board. So I think it's finding that right person that you can work on individually to get them to try to get support at the higher levels. That would be my suggestion.
Okay, I think we have time for one more question, which is, how do you break through to staff that see detention and punishment as preferable over EBPs?
Well, it is sometimes a challenge to convince people to use evidence-based programs instead of consequences. So I think that's always the question, is the service that they're supposed to be getting actually supposed to be therapeutic, or is it supposed to be punitive? And most of the time, detention is used in punitive ways, and the programs that we're talking about are alternatives to that. So I think some of that is trying to get folks to understand that philosophically, it's the right thing to do for kids and families to provide services and treatment and not punishment. However, I've been around long enough to know that there are many people that will never buy into that philosophy. And so I think the better way to approach them is from the cost-benefit analysis. If you look at the Washington State Institute for Public Policy's website, they probably have the most sophisticated system of evaluating evidence-based programs based on a cost-benefit analysis. So they report to their legislator every year about how much money they spent on evidence-based programs and how much money they're saving. So not just in how much they're spending up front, the money that they're saving up front, instead of using residential or detention, which is so expensive, compared to using a community-based EBP, they save money there. But then the long-term cost savings of having less kids in residential and having less adults in prison, because that's what these programs are designed to do, is save taxpayers' dollars. So if you can't get someone on board for the philosophical right thing to do, then I would attack it from the cost perspective, because everybody's interested in saving money.
Yeah, I would add to that, because some of these folks are focused on public safety and behavioral change. As I said earlier, you want to approach this from a joint perspective, so that, if you're addressing their concerns about, making sure these kids are being held accountable, making sure that you're tracking the outcomes. Another strategy is to pilot it, right? So identify people that their philosophy is more in line with this program, so when you're having some successes, you can have their colleagues themselves can advocate for widespread adoption of the services.
I wanted to thank both Frances and Beth Ann for participating in the webinar today. If we weren't able to get to your question, as you can see, their contact information is up on the screen, and they'd be happy to take your questions or follow-ups. Like I said, the PowerPoint and recording of this webinar will be posted on CJJ's website within 24 hours. And with that, I just wanted to thank you all, and have a great day, everyone.
Thank you, Katie.
Thank you so much.